Again, I would like to encourage you to ask questions. We have great group of speakers, so this is your chance to ask them questions. And you can ask directly by typing in the Q&A section. Our last presenter is Dr. Athari Al Deraibi. She will be talking on contact lens and keratoconus.
Good morning, everyone. Assalamu alaikum. I will talk about how to fit keratoconus patient with the contact lens. What is the type of contact lens that we will use to correct the keratoconus patients and any other irregularities in the cornea. We all know that keratoconus, it's a progressive disease. It can be cause a corneal stromal thinning and steepening. Traditionally, was thought that it is non-inflammatory, but recent studies show that it's an inflammatory disease. The onset of the disease will start at the age of 16, and in some cases it's smaller than that. The progression usually will take 10 to 20 years. We need to control this progression or to control these irregularities by either using surgical or non-surgical treatments. I will talk about the non-surgical part. You can use the contact lens or the spectacles to correct the irregularities. So contact lens, it can be either a soft contact lens, normal toric contact lenses, or a custom soft contact lenses for irregular cornea, or by using hybrid contact lenses, hard contact lenses, either corneal, semiscleral, or scleral contact lens. First of all, we need to define what is the contact lens, or what is the main job of the contact lens. We needed to resurface the interior surface of the cornea and correct the refractive error and correct the irregularity of the cornea. This is just a review about the history of contact lens. The first type of contact lens I will talk about is how to treat it with the normal soft contact lens. Usually toric contact lenses, we can use it for the early keratoconus cases. We can, when the K readings, it's 50 diopters or flatter than that. When we do the refraction of the patient, we may reach 20, 30 or better in the corrected vision. We can reach up to minus 5.75 cylinder, which equal to minus 7 during the refraction contact lens. And this design need a special order sometimes with a specific base curves or diameters of the contact lens. This is an example of one of our patients. She's 36 years female. Her uncorrected vision was 20/40. This is a look to her pentacam. As you can see, the steepening is symmetrical in all the cornea with the maximum 51 diopter. When we do her the refraction, she reached 20/20. So we decide to give her a soft contact lens with the base curve of slightly steep. It's 8.6 diopter millimeter base curve and 14.5 millimeter in the diameter. The lens was stable, the vision was clear, and the patient, she was satisfied with her final result. Our second type is the custom soft contact lens for irregular cornea. This is a special design soft contact lens. We use it for more higher base curves. As you can see, it's a custom made. We can do any adjustment on the peripheral curves of the lens. It helps to make the refraction and the lens stable on the cornea during blinking. This would make the high cylinder more stable even with good vision for the patient. So it can cover all corneal abnormalities and post-surgical patients with high cylindrical power. And we can use it also for the patient that intolerant to the hard contact lenses if we need to fit them. But usually we get the best results for early to moderate keratoconus patients. This is the example that I've shown before. This is a 32 years male. His uncorrected vision is 6/200. This is his pentacam result. As you can see, that most of the steepening is in the inferior part of the cornea. If you will use the normal soft contact lens, the lens will be moving and it's not stable. Because of this special design of the cornea for the custom contact lens, it helps us to make this lens more stable during blinking, and that will give us a good vision and a stable vision. When we do the refraction for the patient on the lens, we reach the vision of 20/20. Hybrid contact lens is the second choice, but most of our patients in the clinic, they don't like these types of contact lens. Usually it shows best results in the early to moderate keratoconus patient. It doesn't cover the high K readings in the keratoconus patient. The soft part of the lens, could be either silicone hydrogel or hydrogel. The disadvantage of this lens is it's short in lifetime, and the soft part, when the patient tries to remove the lens, it could be tear while he removes the lens. So when we compare it with the cost of the lens, the patient usually find that it doesn't worth to use this contact lens, so they prefer to go to the next solution, which is the hard contact lens. Hard contact lens, there's 3 main types of these contact lens. Either corneal, semiscleral, or scleral contact lens. No matter what type, we can use any type of these. It depends on the patient cone stage, the cone location, the type of the irregularity there in the map. Also, when we decide which type of contact lens we need to use, we need to study the patient, his eyelids, his eye shape, if he can insert or handle the contact lens, if he can tolerate the type of contact lens. This all will decide what type of contact lens we can use for them. Hard contact lens, or the corneal hard contact lens. Here, all the weight of the lens will lie on the cornea. This is the optimum fit of the cornea hard contact lens. There's 3-point touch, as you can see. The new generation of the contact lens help us to cover high K readings. Usually we may reach 75 diopter with different diameters to cover all the cornea. They are custom made. We can do any adjustment we want to the peripheral edges of the lens to give us a good fitting for this patient and a good vision. This is one example. I have a young male. He is 15 years old. His uncorrected vision was 2200 with the steepest K in the Pentacam map was 76.5, which almost 4.8 millimeter. This is his map. We tried the corneal hard contact lens because it's like a small cone in the center of the cornea, so we use a small diameter contact lens. We've done him also the refraction. We reach only 20/80. So we encourage him to use the corneal hard contact lens with diameter 8.1, and he reached 20/30, and he's doing well with the contact lens. Our next hard contact lens we can use also the semiscleral contact lens, which I recommend it for most of my patients instead of the scleral normal contact lens because it's easier for insertion and removal because it's smaller in diameter. In the semiscleral contact lens, 30% of the lens weight lies on the cornea, 70% on the sclera. It's a good choice for severe keratoconus patients who cannot tolerate the hard contact lens, the corneal hard contact lens, and for those with decentered cone and globus keratoconus. It covers up to more than 70 diopter, different diameters. It can be between 12.5 millimeter or the 15 millimeter. They are custom made. You can adjust the peripheral of the contact lens to fit the cornea smoothly without any problem with the patient. But the main thing in this point that the patient need to make sure that when insert the remove to use the correct way, either by using the plungers or by using 3 fingers technique to insert the lens. Make sure that there is no bubbles in the lens. This is the picture of the optimum fitting. As you can see, there should be clearance in the center of the cornea. You can see the pupil through the cornea, no bubble form when the patient blinking. All this will show us a good fitting. Any irregularities or something different than that, you need to change the lens. This is an example. This is a 34 years old female with uncorrected vision 20/80, the steepest K 48, which is not high, but this is her pentacam. But the patient was intolerant to the corneal contact lens, and always she complained she cannot tolerate the contact lens. We gave her the choice of using the semiscleral contact lens, which is smaller in diameter than the scleral contact lens, and this makes it easy for her to insert the lens also. We done refraction. She wasn't reached until 2050, so this is why the custom contact lens, it wasn't a good decision for her. So we give her the semiscleral, and she reached 20/30 plus in the after over-refraction. The last type of hard contact lens is the scleral contact lens. Here, the entire lens lies on the sclera. It's a good choice for the severe keratoconus patients and the also the post-surgery, post-BKB, post-LKB, post-NSAX patient. We can all use these contact lens because it's depend on the sclera, so it will not contact the cornea. It has different diameters. They are custom made. We can adjust the peripheral also, so to get an optimum fitting. The scleral contact lens, there is no optimum fit for a specific kind. There's three main points that should cover each type and any kind of scleral contact lens. The scleral contact lens mainly divided in through main zone, the optic zone, central zone, which is the central zone, the transmission zone or the limbal zone, where it should be not touch at all at that area while inserting the lens, after inserting the lens, and the scleral zone, which controls the height of the lens and the our fitting at all times. It depends on the sagittal depth of the central fitting. Any changing in the peripheral zone will affect the central zone. This is the most important point where you should take in consideration if we will do a fitting of scleral contact lens: the diameter of the lens, the central and limbal clearance, and the landing or scleral fitting. This is an example. This is a post-PKP patient. He's 31 years old. He's uncorrected vision 20/80. This is his
Dr.
map.
Deraibi, if you don't mind just to conclude in 1 minute.
Okay. This is my last. This is his pentacam. This patient complains always from the corneal contact lens. There is a bubble will form always in the center of the lens, which affects his vision. We've done refraction. He reached 20/40. Always there is a poor fitting. We give him a scleral contact lens, and with after he came back after like 2 months, he complained that there is always a flinging and pain. This is OCT image of the patient and the lens. You can see in the peripheral edges there is a tightness and flinging in the sclera. So we decided to change the fitting of this patient. I will skip this. This is a post-intact patient. We use scleral contact lens also. This is the fitting and then the OCT after inserting the lens. What's new in the scleral contact lens?
If you don't mind, Dr. Deraibi, we have a lot of questions.
Okay,
This
is my last.
Okay.
Okay, this is the new generation of scleral contact lens. It's like a prosthesis, depending on taking a print by using the mold to get a good image of the cornea and the sclera, to avoid any irregularities that cannot be fitted by the scleral contact lens, the normal scleral contact lens. Thank you.
Thank you so much, Dr. Deraibi.